Hello and welcome, everyone. My name is Kelsey Barnes, Senior Manager of Germane Solutions, and I will be the moderator for today's webinar entitled Charting New Paths, GME Strategies for Changing Times. After today's webinar, participants will have gained insight on recent changes in the industry that directly impact GME strategies, understand the relationship and significance of ACGME and CMS regulations, better comprehend learner strategies and clinically integrated training, and know more about Germane Solutions' role in these strategic processes and how we can best support your organization. Before I introduce today's speakers, there are a couple of housekeeping items to share. First is that participants have been muted upon entry to the session. However, this sometimes does not work. If your audio is showing as unmuted, please mute yourself to eliminate background noise during the presentation. Second, we have made every effort to reduce technical issues with the webinar presentation. However, if you are having problems of any kind, please indicate them in a private chat to Hunter Rich on the platform. And third, the slide presentation and the webinar broadcast are provided exclusively for use of the registrants and should not be shared. Reproducing, distributing, or transmitting any session materials or the live presentation to any other groups or individuals requires express permission from Germane Solutions. If you have any questions throughout the session, please submit them in the chat feature. We will be answering questions as they come up, as well as during a dedicated question and answer time at the end of the session. If we are not able to get through all of the questions in the time allotted today, or if you have a question that you don't want to include through the public methods, you will have the opportunity to submit them via email afterwards. Margot Flowers will serve as our chat facilitator today. Following the presentation, every registered participant for the session will receive an email containing a link to our survey so we can obtain feedback about the webinar. Our survey is brief and we encourage and appreciate your comments. Now, let me introduce our speakers. Susan Hearn, CEO, and Scott Masin, Senior Manager, will lead us through our discussion regarding the transformative shifts reshaping GME and the delivery of healthcare. Susan brings over 35 years of experience in healthcare consulting and administration. She drives the overall mission and vision of Germane Solutions and leads all strategic initiatives. Additionally, Scott has extensive background in financial projections and performas that utilize methodologies to incorporate Medicare cost reports and Medicare GME reimbursement. With that, let me turn the session over to our speakers. Scott, you may begin. And you are on mute, Scott.
That's a terrible way to start. So we'll be jumping in today to talk about some industry changes throughout the GME world, and I'll just get right started here. So traditionally, the thought process was that hospitals had a one-time cap development opportunity, where in 1996 or in their first 5 years of graduate medical education development, however many residents they have at either end of those 5 years or in 1996, they're basically capped for good, and they're not going to have an opportunity to be able to create new funding for any newly accredited programs. And we're really seeing a shift here where there is hope. There are some opportunities now for these hospitals to get new funding and to really be able to expand their GME footprints and not just fund them out of pocket, but be able to have more funding to pull down from CMS, which makes these a lot more financially advantageous to a lot of our clients across the country. So the first one, and this is one that from some of our other webinars that we've hosted, we have gone into a lot of detail on, but is the rural reclassification, rural designation, rural reclassification strategy. There's a couple different names for it. At this time, over 600 hospitals have done this since 2017. This is something where in 2017, a precedent was set by Geisinger Medical Center. And from there, it basically opened this loophole for a lot of hospitals all across the country to be able to follow in the same suit. This opportunity, the main one related to graduate medical education, is you're able to build new IME cap on a program by program basis. This is something that is a huge deal to many of our clients because they traditionally thought, well, the programs that we have we're really going to sit right at this cap, trying to kind of balance, do we close some programs? Do we shrink some programs? Just so we can stay at the cap if we want to expand others. But this really opens the door to be able to expand the number of programs that they're training significantly. And that's why a lot of our clients do this. But there's also an immediate 30% increase to 1996 cap. And this is something where it's not applicable to all clients, especially if you have new cap. But for a lot of hospitals that have had historical training, this increases their funding significantly. And for a lot of hospitals, this was a big windfall for them when they were training so far over their cap. And then there's some other non-GME reasons that we'll not get into today, but many hospitals have done it for these reasons as well, where it allowed them to get potentially paid at a higher rate for the services that they provide. When we look at who qualifies for this, traditionally, CMS set this threshold of 275 beds. If you're over 275 beds, it's really no questions asked. You can do it as long as you meet a few other criteria, which we'll cover here in a little bit. If you're under 275 beds, you can still qualify for this as well, but there's some additional questions and qualifications that you need to meet, including servicing the rural area in which you're located, but that can be investigated. But really a true opportunity for a lot of these hospitals that were historically stuck at that cap from either 1996 or when they finished their cap development period. The one piece that is bad news for hospitals located in New Jersey or Rhode Island is that they do not have a rural area designated within their state. This rural area is required in order for these hospitals to rurally reclassify. And so in working through this and identifying this opportunity, hospitals located in these two states are put at a significant disadvantage compared to the other states across the country. And this is something that we've been trying to kind of bring together our clients in those states to try to influence change. And through some other work that we've been doing more recently, we have been able to get state support. We have been able to get senators to help advocate for these folks to increase their funding for various opportunities. But this is something where if enough people come together, this is something that can truly be changed. And we're hoping with some of the reclassifications of these various areas, as different censuses come out across the country, we may be able to get to a point where there are rural pockets in these states. But I think unless there is some coming together and unless there is an opportunity to advocate at the state level with a lot of support behind it, it's going to continue to sit this way, and these states are going to continue to be ineligible. So system mergers and consolidation. So I think every time that I open up some of the updates that we get for healthcare, there's always purchases of hospitals. There's consolidations of health systems. There's mergers of different areas. And there's really a lot of impact that this can potentially have on graduate medical education, both positive and negative. I put some of the questions in here that we tend to get. Do we purchase and open a new provider number? That's a great question. What impact could that have on graduate medical education, whether you were historically a teaching hospital or if you are a non-teaching hospital? What sponsorship should we use for the program? Should it be a single site? Should it be a consortium? What makes the most sense? Are there benefits or disadvantages to consolidate it under consortium? How much am I going to get funded at this hospital that I'm thinking about purchasing or that I already purchased? This is a big consideration for a lot of our clients, because if GME is part of their strategic plan and the hospital that they're looking to purchase may not get good reimbursement, it may not be the best financial opportunity for them. When do I trigger cap development? Is it the right time to do so? We know that we only have 5 years to build our cap. Should we do it now? Should we wait till there's additional development at the hospital before doing so? There's a lot of questions that come into play as to what the timing should be for our new program development. Is there opportunity for Medicare GME affiliation agreements? For those of you who didn't attend some of our previous webinars, Medicare GME affiliation agreements are an opportunity to share cap from one location to another. And with acquiring in different hospitals and or expanding the reach of the health system, you open yourself up to a greater opportunities for Medicare GME affiliation agreements. And are there maybe either educational experiences or their financial benefits that we may be able to uncover through some of these mergers and acquisitions? And then can we expand care to rural areas with GME? And with some of these, with some of this consolidation that we've seen, these smaller rural hospitals are joining with these large health systems. Historically, there really hasn't been an opportunity for teaching at these locations, but can we have a rural training track? Are they big enough to maybe base a whole program there with the support of the larger hospitals in more urban areas? But these are all opportunities where, when we're thinking about these consolidations, there's a lot of things that go into this, a lot of factors. But graduate medical education should definitely be one of the considerations, because there is a lot of changes that could be made and a lot of impact that has downstream effects. So the Consolidated Appropriations Act, this is something that when we talked earlier about there is hope. This is something that CMS released in 2020 and really came into effect in 2021, but allowed for hospitals that had set a de minimis cap to be able to create cap moving forward in the future, as long as they met some of these various criteria. And so this is something where, as I mentioned before, these hospitals think, we were set back in 1996, or we were set in 2005. There's no opportunity for us to ever create their cap. And this is one where they specifically, CMS intentionally opened this to say, we want to be able to let these hospitals that inadvertently set their cap to create new funding. And there's a couple different thresholds that you can't surpass. You need to be less than 1.0 FTE on your 1996 cost report. You cannot go over 3 FTEs at any point thereafter. But as long as you're meeting these and can demonstrate to CMS, you can reset your cap as long as you start a program by July 1, 2025. And this is something that is very, very quickly approaching, because as you all know on the call, programs cannot get started overnight. But if this is something that you all are interested in, these conversations need to be happening very soon in order to get that cap reset. It's really great to see the government going through changes that are positively impacting GME. And this is happening at both the state and the federal level. And that kind of brings us to our next point here for state funding. 44 states are now kind of making payments for graduate medical education through Medicaid. And this is something where it's very state specific. There may be small funding mechanisms, or maybe very large funding mechanisms. And this is all outlined within the state planned amendments. And we want to make sure that all of the funding that you are due for is what you're receiving. And the items that normally play into this are the number of residents you're training, the Medicare PRA, and then the utilization percentage of the Medicaid population. The one important distinction between state funding and federal funding is that the federal funding is limited by these caps that we were referencing earlier. So this cap is basically set, and CMS says we are not paying over whatever that cap was that you set during either cap development period or in 1996. And the count is how the state funding mechanisms work through their funding. Even though the Medicare has these caps that they've implemented, the states are really trying to incentivize graduate medical education, and they do not have these caps from what we've seen across the country. And it's very important that if we look in the lower box here, even if you're training over your cap, this is something where you need to continue to report all the FTEs that you're training in order to maximize the Medicaid funding. Historically, there had been some, it was called the DGME penalty. And if you are training over your cap, they actually reduce the funding that you received on a per resident basis for whatever reason. But recently that was overturned, and really now there is no negative impact from training over your cap. And on the Medicaid side of things, it can actually increase your funding at the end of the day. So just going over these 4 recent legislation changes that came into effect. So rural designation, 30% increase in 1996 cap, and you're able to build cap on a program by program basis thereafter. System mergers, those various questions that I went through. Really, how does this merger, how is this consolidation of hospitals or health systems, how does this impact future growth, future and or existing GME operations? Section 131 resets your per resident amount or FTE cap for various hospitals that qualify or met those thresholds that I mentioned earlier. And then the state funding, making sure that we are maximizing that reimbursement that you're receiving year over year by getting the appropriate FTE counts that are rotating through the various hospitals. So the next piece that I'll get into is CMS and ACGME. So it's always interesting seeing these two interplay off each other. So the ACGME, their Accreditation Council for Graduate Medical Education, they're the ones that oversee the training programs for the residency programs. CMS is the funder for these programs. They're the largest funder for these programs across the country. Obviously, I mentioned before, there's state and other private opportunities as well, but they're the one predominantly providing the funding. There's not a lot that ties these two together other than in the CMS legislation, they specifically note the ACGME as one of the accrediting bodies that they identified, which can create this new funding mechanism. So making sure that we understand both these rules is very, very important in how they interplay off each other, because if we just look at CMS, we may not have the correct understanding from the ACGME side of things. And if we're just looking at specifically training the residents, we may not ever be able to create funding opportunities for those residents. So it's very important to see the two and how they interplay. So one additional item that we've been talking about more recently is duplicative programs. And for the duplicative programs, this is something that we've talked about, or the example that we use most frequently is internal medicine. And for these programs, there is an opportunity where if you have one internal medicine program within your system, you may be able to, instead of saying, we need more residents within this program to provide care for the patients, we could potentially create a new program that would create new funding for those programs. And so what we've been looking into and what we've done with some of our clients is we build this duplicative program to expand the services of the residency programs. Recently, CMS came out with their proposed rules. It was actually April 10th, and they're actually addressing this specifically. And they're asking for comments to say, what really means it's a new program? Like, how do you define this? How is this not an expansion of an existing program? And it's interesting that CMS is now coming up with policy to say, how do we keep this cap at a manageable level? What are ways that we can kind of fight against expanding this and paying for more programs? So we'll get into this in a little bit here, but it's very important that if you all are considering some of these opportunities, that you're providing feedback to CMS to help influence the future policy and really have opportunities that and really give you those opportunities to make expansion at your hospitals. Some examples of some of these duplicated or targeted programs. Instead of saying a hospitalist focused track of internal medicine, you could potentially have an internal medicine program with a hospitalist focus. This gives us an opportunity to really create the same type of physicians that we are intending to with the track, but instead we're going to have the opportunity to create new CMS funding for these various programs. Instead of a rural elective track of OBGYN, potentially a rural OBGYN program. There are specific rules and requirements that are a little bit different for rural programs compared to urban. But regardless, some of these opportunities where if we could break off some of these tracks, or if we can make these more defined programs, we're able to create more funding from CMS. The last piece I'll mention is, like, how do we know if this is a eligible track for this or how do we know if this could be a new targeted program or a duplicative program? Usually the track has to be a little bit larger. If it's just one resident per year, that's really usually not enough to be able to kind of break away and be on its own. If you have residents that are multiple residents per year that are continuing to go through this track, those are the ones that are a little bit more ripe for this opportunity and able to kind of expand and create new funding for these opportunities. And one of the last things that I wanted to touch on here was some of the new distributions from CMS. So we have two here, and there's actually a third one that was just released as part of those April 10th opportunities, or the April 10th proposed rules. So Section 126, I think that probably a lot of you know about this opportunity already. So 1,000 FTEs are being distributed over 5 years, or 200 per year. And this is where there's basically an application process that closes at the end of March, and then they're distributed later that year to the hospitals depending upon their eligibility. But this, from our point of view, is a great testament to CMS and how they're trying to expand this funding. Some of the operations, or some of the effectiveness of some of these things, it leaves a little bit of questions unanswered. But regardless, knowing that they're trying to expand the number of slots in funding for graduate medical education, it really comes to show that they know that having the funding is one of the most important pieces to expanding graduate medical education across the country. And that's one of the main opportunities to address the physician shortage that's continuing to grow. Before I jump to Section 126, there was a new section that was introduced in the proposed rules. It's Section 4122. And this is where they're actually distributing, in addition to the 1,000 they've already tagged, there's another 200 FTEs that they're distributing in a very similar process. They're really actually following the same rules as Section 126, but the biggest variance from what's already in place is that 50% of the FTEs need to go towards psychiatry programs. So this is one of their efforts in trying to expand the psychiatry care across the country and expand it to those in need. For Section 127, this is an opportunity where trying to create programs in rural areas is very difficult. And CMS does a couple different, they have a few changes to their rules and regulations for rural areas that makes it a little bit easier. But this is another one of their attempts at doing this in order to be able to expand existing programs to provide tracks to these various areas, but a new separately accredited program is not part of it that's required. So it really makes it a little bit easier for graduate medical education programs to get into some of these rural areas, and you don't have to go through the full accreditation process, which is rather time intensive. And as it's been defined before, at least 50% of that training program needs to be located in a rurally geographic area. And that's not to be confused with what we talked about earlier as far as the rurally reclassified hospitals. This truly has to be a rural area in the traditional sense of the word. All right, so as I kind of hand this off to Susan, one of the other big industry shifts that we've been seeing is learner strategies. A lot of health systems, medical schools, health science centers are really starting to align to be able to create these training opportunities for various levels of learners. And Susan's going to go in a little bit more detail to talk about how that's going on currently and where there's opportunities to improve some of those strategic opportunities. So turn it over to you, Susan.
Thank you, Scott. Go to the next one. So we're going to start by looking at key training sites for GME and how these have evolved over time before we get into the learners themselves. This is the classic traditional model that you see here, the academic health system. This is where you have the University Medical Center serving as a primary site to train students and residents. The hospitals are typically tertiary care centers, and they are organizationally and administratively tied to a medical school. And that's really what defines the academic health center. It makes sense when you think of this partnership here, when you look back in history and you take a look at the Flexner report, which people that have been around for a while probably have heard of. It was published in 1910. Dr. Flexner was asked by the AMA to evaluate and restructure medical education. His report identified poor quality, inconsistencies, lack of standards, and resulted in closing of about 55% of medical schools back in the 1900s. This instigated a profound transformation of medical education, and that's what nurtured the development of the academic health center. Next one. The next one, this involves community hospitals. So we all know community hospitals, single short-term hospitals, and then health systems. A health system is really, we think of it a lot of times as the multiple hospitals, which it certainly can be, but the real definition is that it is health related organizations that are together. Very typically multiple hospitals. They can be short-term, they can have an academic medical center associated with them, just kind of depends. There is a growing trend in this area, however, to sponsor GME. Some things that have kind of pushed it and funded that growth is the physician shortage, certainly the need for physicians in smaller communities and rural areas, and also the ability to get funding. Go ahead, Scott. Thank you. And then the next one is the Health Science Center. So this is kind of the new one on the path. It's something that has been around for quite a while in certain instances, but it's really growing in popularity now. So the focus on additional learners has really created this Health Science Center, which is basically an academic health center that is combined with a medical center, so a medical school, and then also a health science education. So that can be something that has to do with nursing, dentistry, public health, all kinds of different areas that would be inclusive in that. We'll take more look at the learners. So then this is the kind of the spectrum. So on this slide, we illustrate the spectrum of integration and capability from community hospitals on the far left. Those are single short-term, may or may not have teaching. Health systems, multiple organizations may or may not have teaching, onto academic health systems where you have the affiliation with that medical school, and then the Health Science Center, which is a broader range of health-related disciplines and the tie to the health sciences and the allied health. This is where other learners come in. You may see other learners in the previous models, but there's not typically a strong affiliation as there is in a health science center. At the bottom, you can see there are other training sites that can include FQHCs, clinics, physician practices. FQHCs can also sponsor training programs via the Teaching Health Center. And I'm going to step back for just a moment to the medical schools and talk about why hospitals and health systems partner with them. The partnership supports the teaching organization's tripart mission for patient care, teaching, and research. The hospital is obviously very critical for adequate clinical training. They have the patients. This is where we have to do the clinical part of the training. And the hospitals also benefit from a workload perspective to some extent with these trainees, and also the recruitment of the trainees, which is becoming a really important factor. Services and resources are required from both organizations to truly support both the teaching and the research mission. And some things to think about here that are received include SimLab, faculty development, faculty appointments, CME, and certainly reputation is another reason that people often affiliate with a medical school. And we see this a lot here, one for the provision of services, but also just in looking historically, it has proven to be a successful partnership in terms of advancing the practice of medicine and also the health of communities. So let's look at their learners for health science. So first, the definition: health science is a study of applied science that deals with human, physical, and behavioral well-being. So we're familiar with a lot of these: medicine, nursing, pharmacy, dental. Those are the key ones that we typically see. And then allied health is a group that I think a lot of times we think what goes in there, but it's basically everything else it supports. So let's go to the next slide and we'll dive a little deeper. So these professionals provide healthcare by assisting primarily the medical, nursing, pharmacy, and dental professionals in the area in the roles that you see down below. So a primary care provider can be a dental hygienist. They're providing one-on-one care to the patient, kind of under the dentist. A CNA is doing the same thing, kind of under the nurse. We have psychologists, social workers, nutritionists. Diagnostic, I feel like this is an area that typically when we think about allied health, it makes sense to us. We see rad techs, ultrasound, nuclear, sonographers. Health professions, certainly an area that's growing with the focus in today's world on health education, health promotion, certainly health coordinators. Rehab, again, areas that we recognize: OT, PT, speech, respiratory, kind of throw in art and music as well. And then the last one is administrative. So we don't, I think, often think of administrative as being an allied health professional and working there, but as they're related to the care of the patient, things such as coders, transcriptionists, medical billers fall into that area. And all of that incorporates the allied health learner. So in looking at key trends impacting GME and learner strategies, Scott went through some of these with you. There are a number that have impacted and will continue to impact the industry. It's certainly well known that there's significant financial pressures still in the industry, some still related to COVID-19 and the impact of that. There are certainly financial pressures related to labor and supply chain shortages, rising costs. I could keep going with the list. There is a critical shortage of healthcare professionals. So we are all familiar here on this call probably with the physician shortage and the projections out there. But these shortages apply to other disciplines as well. In a recent study, they reported that 89% of healthcare managers are struggling to find talent. 30% of professionals are considering leaving their profession, and 60% of professionals are still reporting post-pandemic mental health issues. There are certainly continued health inequities, patient access issues, particularly in underinsured, underserved rural populations. And then finally, consolidation in the industry. As we know, it's been a defining trend in the U.S. healthcare system. If we look at the stats overall, the first big wave started in the 1990s. We've gone from that period of 8,000 hospitals to approximately 6,000 hospitals. So pretty significant consolidation. And we do certainly anticipate more. As Scott mentioned, we're seeing health systems consolidate. We're still seeing the pickup of a single hospital or large mergers. We also anticipate seeing the use of different types of learners and different ways to teach. So as we begin to look at the integration of learners, there's a wide spectrum to think of first from an administrative and organizational basis. So this type of integration is typically the first step before we get to true clinical integration. The first one we see on the left is an unorganized. This is where there are silos. Even today, and certainly historically, most training has occurred in silos, and learners are coming into those silos from multiple entries. So there's not a consolidated effort to bring learners in. There's often multiple contracts and uncertainty in the organization of where there are learners. As we move to coordinated, there's a more limited ability for people to contract to bring learners in. You may begin to see some groupings or some schools that are becoming more priority. And so we have kind of a better understanding of learners. And then as you get to strategic, there's an effort to identify strategic partners and really prioritize those learners. So at this point, typically we're seeing arrangements with schools, colleges, maybe hospitals or health systems that we're going to prioritize the learners and really try to leverage those partnerships. And then the last step is centralization. This can occur at many levels with many different learners. Sometimes all learners aren't consolidated into one single point. Basically, we're limiting again further how learners come into the system and really determining strategically who we want there. So ultimate consolidation would be a single entry for all learners and beginning to have that collaboration, at least in onboarding and training. And then the next level is where we begin to see interprofessional teams caring for patients. So clinical integration, or IPE, or interprofessional education, as it's been called in the past and sometimes still today. Historically, we talked about how different disciplines are educated in their own silo. They typically don't have any interaction with other professionals until graduation. And that comes despite attention as far back as 1960. In 1972, the Institute of Medicine reported that they strongly recommended IPE. So why didn't it take off? I mean, it's starting to take off now. We see it in different instances, but still not completely prevalent in the industry. Certainly logistically, it can be challenging from a scheduling perspective. But I believe the bigger piece in that is really the lack of urgency to make changes and also the political dominance of the physician. We are seeing some movement today. I think that movement is likely due to a growing body of evidence about patient outcomes, as well as pressures to improve experiences, costs, and learner retention. So diving just a little bit deeper, looking into integrated clinical training. What is it really? It's the coordination of learners from various specialties to work in teams. The goal is that we're training them in a way that we hope that they will practice. I think that we see a lot of teams working as professionals, particularly in academic medical centers. So if we begin to train them that way, then they'll learn that coordination and the benefit of that. I think one important thing is that in these teams, they learn with, they learn about, and they learn from each other. So if we look at what they share, one of the easier things to share would be certainly orientation. We get that administrative consolidation. They come in, they share some parts of orientation. SimLab is an area that early on we see some sharing. We can begin to move to didactics, to patient-centered care, sharing of experiences to provide care in both the hospital or the community, and certainly care planning. From a benefit perspective, this training impacts learners, it impacts patients, and it also impacts the organization. Some of the key benefits that we get: better learning experiences, learner experiences and satisfaction, better patient experiences and outcomes, more creativity and innovation in care planning, so we get a better result for our patients. And organizationally, it allows you really to leverage the learning environment, kind of offload some stress in your overburdened areas such as ICUs. It also lowers cost and creates higher retention. Successful implementation of this certainly isn't a quick and easy movement to get to here, but it does need to start with a vision. It requires significant change management, culture change, coordination, and strong leadership. So this concludes our presentation today. We will be having another webinar later this year focused exclusively on the topics of learner strategies and integrated clinical training. And I'll pass it back to you, Kelsey.
Great. And we will now open the floor for questions from the audience. If you have a question, please type it into the Q&A box. And I know we've already received some. We're going to start with, what impact does role designation have for a hospital other than GME?
I mentioned a little bit of that earlier, and we're specifically talking about there's two reasons for graduate medical education: the 30% bump in the 1996 IME cap, and the ability to create new IME cap on an ongoing basis. The third one, just to dig in a little bit more, is when you rurally reclassify, you have more opportunities to reclassify different areas for specifically the wage index payment, the wage index payments. So the wage index payments are applied to each and every DRG that flows through the hospital. And if we could potentially have an opportunity to increase that, that factor by even a small amount that was not previously available to us under the urban rules, that change can be worth millions and millions of dollars to hospitals and health systems. So that's the third one, that a lot of hospitals, that's the reason that they're going after this rural reclassification outside of graduate medical education.
And there's just one other one as well that I'd like to mention, which is lowering the floor for 340B. So if you all are familiar with the 340B, kind of the pharmacy payments, it does lower the floor so that more people can qualify for those.
Thank you both. Next question is, how can we impact future policy related to graduate medical education?
Absolutely. So as I mentioned, there were several proposed rules that came out on April 10th related to graduate medical education. And for most of them, they actually asked for either information or comment to make sure that CMS has all the information in order to make an informed decision. So specifically requesting for comment. This is one that's talking about the newness of residents and how that may impact CMS's determination of a new program. There's opportunities to provide feedback on the CMS website, and I can put that link in the chat just to make sure everyone has access to it. But that's the simplest way from this point of view. But as I mentioned on the rural reclassification for Rhode Island and New Jersey, this is something that really takes the conglomerate of hospitals and health systems to advocate together in order to make those changes, say to get that rural area introduced into one of those various states. So collaboration is the one answer, and the second one is we'll provide the link to provide feedback to CMS on future policy.
Thank you, Scott. Next question is, why are CMS and state legislation providing additional funding for GME at this time?
They've specifically seen the return on investment for putting money into graduate medical education. Some of the states that have earmarked significant dollars for GME, they've seen the physician shortage in their states go down. About half the physicians that train in the state, they normally stay in that area. So it's a lot better opportunity if you have more residency programs in your state to be able to influence where they continue to practice after they graduate. And furthermore, there's a nationwide physician shortage as well, and CMS is jumping on board to try to just increase the total number of training opportunities for residents and fellows across the country.
Right. Next question is, how can we get started on a path towards clinical integration?
Sure. So I think the first thing is really understanding the learners that you have. I mentioned that first state where it's very unorganized. We are called by organizations all the time that say they don't know where their learners are, who they are, and not sure how a contract got signed. We've actually seen several hospitals whose cap was blown because some residents were allowed in to rotate, and kind of the financial team really didn't know about it, so the cap had started. So there's a lot of issues around that. So I think certainly understanding where your learners are first, and then moving through kind of mission and objectives that you want to accomplish. It's very important that you have that, because you're going to need to have that mission, vision, and leadership to get there. After that, it's really working through the process to implement change. Don't be in a hurry. It's not easy. It takes a while, but certainly is accomplishable. And there's a lot of small steps along the way that can, really be successful.
Great. And the last question we have posed at this time, unless there are any other additions, how is ACGME approaching IPE?
So ACGME has certainly changed some things within the, kind of the rules about what needs to be like oversight, what needs to happen there. So there's some things within that. They don't have anything really to do with the other learners besides residents. So they're not doing a lot, but certainly during COVID especially, there was some recognition about how resident roles needed to change to a place where they weren't before, and how interprofessional teams worked. So I don't think we're going to see a lot specifically from ACGME.
And there have been some recent changes within the applications, the new program applications as well, that ask about how is this going to be part of an interprofessional team, or how is this going to be integrated into the existing operation. So it's nice to see that they're asking about it. I don't know if they're necessarily going to take the next step and like enforce it necessarily, because they're kind of just over the residents and fellows, but hopefully it's something they continue to focus on in those applications. I think there was one other, the psychiatry redistribution of those slots at section 4122. And I can follow up and send you exactly where that's at in the federal legislation if you want to read more about it.
Wonderful. Well, thank you to our presenters for the information and insights provided today. In wrapping up our session, we also want to thank all of you for participating. As noted, you will receive an email this afternoon with a short survey to complete, as well as a copy of the presentation. If you have any outstanding questions after today's presentation, please email Hunter Rich at hrich@germane-solutions.com. For additional educational information, please also note that our next webinar will occur later this summer. Details and registration information for this upcoming webinar will be found on LinkedIn and on our website. Our marketing team will also ensure that every participant in the webinar today will receive an email containing a sign-up link for the upcoming webinar. To be included in any important future announcements, please follow Germane Solutions on LinkedIn or contact us on our website. Thank you again for your participation in today's webinar, and I hope you have a wonderful day.